right, thank you for that introduction. This is the last talk before a break, so we'll jump into it and then we'll be able to take a short break. Here are our learning objectives. So conventional imaging, we've already heard this mentioned a few times today, and it's a good reference point for us. This is bone scan and CT scan, something we're very familiar with and widely available. Low cost, and conventional imaging has been used in many instances to define the disease states in advanced prostate cancer. Trials like the CHARTED trial used high volume as defined as greater than or equal to 4 bone metastasis, at least 1 outside the vertebral column or the pelvis, and or the presence of visceral metastasis. Latitude, it used a high-risk definition of 2 or more of Gleason grade greater than 8, greater than or equal to 3 bone mets, or visceral metastasis. But newer advanced imaging, like PET imaging, has come on the scene. And PET basically is a prostate cancer avid molecule like choline, fluciclovine, or a PSMA analog tied to a positron-emitting radiotracer. So that would be like carbon-11, F-18, or gallium-68, and then fused with CT or MRI. Guidelines have gradually shifted over time from initially just considering PET as an alternative or an image that could be obtained if conventional imaging was negative. Now we see guidelines recommending PSMA PET preferentially. And so there's been this migration from conventional imaging to next generation imaging with PET. What are our PET agents that are available? Well, there's 3 different PET images that are considered next generation and are available to some degree. The first, choline-11, it's basically a PET that takes advantage of the cellular membrane synthesis that is ongoing with prostate cancer cells. The issue with choline PET is that it has a very short half-life, and so you need an on-site cyclotron. So its access has always been limited. The next PET agent that came on was fluciclovine, or trade name Axumin, and it's a synthetic amino acid PET. So increased uptake of amino acids during cellular metabolism from prostate cancer cells was exploited for this, and it was used to identify recurrences, and one of the benefits is that it had minimal urinary excretion. So for a period of time, this was widely available, but more recently, PSMA PET has come on the scene. This takes advantage of the PSMA protein, which is a transmembrane glycoprotein, specifically overexpressed in prostate cancer cells. And so there's 2 different PET tracers. There's F-18 PSMA PET and gallium-68 PSMA PET. Both of these have been shown to have higher sensitivity than the other ones. And basically, they've kind of taken over next-generation imaging for those purposes. So going forward, we'll pretty much focus on PSMA PET. FDA approval for PSMA PET was initially in 2020, December 2020, and this was based off of studies that happened at UCLA and UCSF, initially with gallium-68 PSMA PET, and then in May of 2021, a commercially available F-18 PET was approved based off of the Osprey and Condor studies. These 2 studies looked at patients who either had a recurrence after prostate cancer and had negative conventional imaging, or those who are high risk for prostate cancer metastasis who are undergoing surgery. So the reference was really just the PSMA PET compared to either its historically negative conventional imaging or surgery. From there, the ProPSMA study was a head-to-head trial done comparing PSMA PET to conventional imaging in patients who hadn't been imaged before. So this was 302 men who were at high risk for prostate cancer, underwent PSMA PET or conventional imaging. The primary endpoint was the accuracy of the first-line imaging, and PSMA PET was shown to be significantly more accurate, and it also improved sensitivity and specificity. An additional potential benefit is that PSMA PET was found to have lower radiation exposure. So now this, with the ProPSMA and the Osprey and Condor study, there were multiple PET images that were PET tracers that were being approved. When we think about PSMA PET, and this has already been mentioned by Dr. Borjan, is how is this going to impact how we take care of patients? Specifically, he had mentioned the EMBARK trial, And interestingly, this is a study out of UCLA where they took patients who were otherwise candidates for EMBARK and retrospectively looked back to see what their PSMA PET had shown. So 182 men who had negative conventional imaging. If they had a prostatectomy, their PSA had to be above 1. If they had radiation, it had to be above 2. And they had a rapid doubling time of less than 9 months. So in this retrospective study, they found that PSMA PET was positive in 84% of patients overall. This basically would say that that EMBARK population, whom we think would benefit from combined ADT, about 84% of them were actually positive in the face of negative conventional imaging. And specifically, 46% of them had metastatic disease. So we see that advanced imaging, particularly PSMA PET, may really impact our thought process for what we've been using historically as conventional imaging and categorizing patients and their subsequent treatment. So now we'll go over several guidelines and just look at the impact of PSMA PET over time, starting with AUA, looking at NCCN, and also EAU guidelines. And you'll see with AUA guidelines, over time, the endorsement for PSMA PET has steadily changed. So here in the clinically localized prostate cancer guidelines from 2022, it suggests that PSMA PET can be used in patients as an alternative to conventional imaging. More recently, in the update to the Advanced Prostate Cancer Guideline that came out in 2023, the guidelines suggest that clinicians could utilize PSMA PET preferentially in patients who have a PSA recurrence after failed local therapy, or as an alternative to conventional imaging if they had historical negative imaging. In the 2024 guidelines for salvage therapy, the AUA recommends that PSMA PET can be used in the face of biochemical recurrence after radical prostatectomy in those who are considering salvage radiation therapy. Dr. Borgen specifically pointed out that even with negative PSMA PET, we would still consider proceeding with salvage radiation therapy, but nonetheless, a recommendation for PSMA PET to begin with. As we look to MZ or CRPC, PSMA PET can be used in these patients, and as you continue to treat them at 6 to 12-month intervals, you could obtain repeat imaging. And finally, for mCRPC, PSMA PET can be used in patients who previously received docetaxel and an androgen pathway inhibitor as a way to identify patients who may be candidates for lutetium. And we'll talk a little bit more about lutetium here in a little bit. So moving on to the NCCN guidelines, the NCCN specifically identifies PSMA PET as an alternative to conventional imaging, and it states that conventional imaging is not needed prior to PSMA PET. So we can consider PSMA PET to be equally or even more effective in frontline imaging, both as initial staging and at the time of biochemical recurrence. If you don't have PSMA PET, you could also consider choline or fluciclovine PET, particularly if you're trying to diagnose small volume recurrences. For patients who are undergoing initial staging, the NCCN identifies those with unfavorable intermediate, high, or very high risk as potentially benefiting from PSMA PET to evaluate for the presence of metastatic disease. The NCCN guidelines specifically say that PSMA PET should be done before the initiation of ADT because that could improve sensitivity. PET imaging may change your treatment, but unfortunately, we're really not sure if PSMA PET will change oncologic outcomes. And specifically, the NCCN guidelines discuss the potential that what we're creating is a Will Rogers effect, where we're basically moving patients who have a higher risk disease into a different category and keeping those with lower risk disease, and thereby making both groups look like better outcomes. So that's a potential, but nonetheless, I think PSMA PET is starting to proliferate and is helping to correctly identify patients who have metastatic disease. Oftentimes, you may see a report where they consider or they use a reporting guideline as a way to describe the PET findings. I think this is more of an academic issue, but the NCCN guidelines suggest that there is no set reporting guideline. No radiographic or clinical society has ever endorsed a guideline as something that should be used in standard practice. There are several different guidelines depending upon what situation you're in. So like the PROMIS 2 guidelines, which is the like a TNM staging for advanced imaging, is available if you wanted to consider staging a patient. The primary guidelines are used for identifying prostate cancer within the prostate in patients who may be undergoing a biopsy. And the RECIST is very much like RECIST categorization, where you're looking at the response to treatment over time. Basically, these are more of an academic issue. So when you look at these reports for PSMA PET, the terminology used by the radiologist may be highly variable. The EAU guidelines in several different instances caution the use of PSMA PET and how it may impact subsequent treatment. As a summary, they just say that PSMA PET's more accurate, but to date there's no clinical data supporting subsequent treatment management. And in patients at any risk group, treatment shouldn't be changed solely on PSMA PET. For those with high-risk disease, when we use PSMA PET, we should be aware of the lack of outcomes data supporting subsequent treatment changes. However, the guidelines go on to suggest that in patients who have a persistent PSA after radical prostatectomy, PSMA PET could be used, particularly those patients who have a PSA above 0.2. And in patients who have biochemical recurrence, PSMA PET could be used both after surgery and after radiation as a way to evaluate patients for metastatic disease. The EAU guidelines specifically identify a PSA of 0.5 or above as potentially increasing the positivity rate of PSMA PET, and I think that's a helpful reference as we think of things clinically. Moving from the guidelines into Theranostics. Theranostics is basically the combination of both therapy and diagnostics, and PSMA PET is one of the only theranostic approved agents available. So basically, you're looking at a radiolabel ligand that is both a predictive biomarker and a therapeutic agent. This is really precision treatment that is transitioning us from conventional to personalized imaging through the radiotracer and its ability to target prostate cancer. So the first approved theranostic agent is lutetium, approved in 2022. It's a beta particle radioligand that targets PSMA-expressing cells. It was approved based off of the VISION trial, which is a phase 3 trial of lutetium plus standard of care versus standard of care alone. Inclusion criteria for this were men who had previously received one AR pathway inhibitor and 1 or 2 regimens of taxane chemotherapy. They all had a PSMA PET with positive lesions. Lutetium was added to standard of care and was shown to improve both progression-free survival and overall survival. The VISION trial led not only to the approval of lutetium, but also corresponding approval of gallium-68 PSMA PET as a way to identify patients who would be eligible for this treatment. And so ultimately, FDA approval for lutetium. We see that while the VISION trial led to the approval of gallium-68 PSMA PET, the NCCN guidelines support either gallium or F18 PSMA PET as a way to identify potential patients for lutetium. And from there, we see that PSMA PET may be not only an opportunity to identify patients who are candidates for trial, but also as a response marker. And this is the ENZA-P study, which was a phase 2 trial of docetaxel, an androgen receptor pathway inhibitor naive men with mCRPC. They received as treatment enzalutamide with or without lutetium with an adaptive dosing regimen that was very novel, either 2 doses or 4 doses based off of the PSMA PET that was obtained after 2 cycles. So looking at this combined treatment with an imaging-based adaptive dosing improved PSA progression-free survival, overall survival, and some health quality-related outcomes as well. So we're really starting to see not only PSMA PET as a way to identify patients, but maybe also as a treatment response marker. In conclusion, we have conventional imaging. It's widely available, still used to define our disease states, but now we have advanced imaging with PSMA PET, which is more sensitive than conventional imaging. We have to be careful because it's not entirely clear that PSMA PET is changing our outcomes. We have these definitions for patients like mCRPC and high and low volume disease that have been predicated on conventional imaging, so we have to be cautious about how PSMA PET will impact these patients. We certainly have clinical trials that are ongoing, and some like the ENZA-P that I've already shown that PSMA PET may help us guide our treatment responses, and there are more studies that need to be done to understand how well PSMA PET may impact our clinical outcomes. We have to be careful for that Will Rogers effect, where we're just recategorizing patients and then thinking that we're doing a better job, but really we're just identifying people who otherwise had occult metastasis. And then finally, lutetium is our first drug as a theranostic that both combines image-linked biomarker with a therapeutic agent that has led to increased survival in men with mCRPC. So, thank you for listening.